the timer, and here is your question. Right. So if you have read and understood, kindly begin your examination station now.
Okay. Hello, sir. Hello. I will wash my hand and then. Hello, I'm Dr. Muhammad, the treating doctor of today. May I confirm? May I confirm my name and age, please?
I'm Samantha. I'm 50 years old.
Hello. Nice to meet you, Mrs. Mensa. Today I will do examinations of your heart. This will including looking and feeling and hearing with a stethoscope. Are you okay with that?
Yes.
Do you feel any pain at the moment?
Little bit, but that's all right. You can go ahead.
Yes. I know that you have an chest pain. So I will start by I will be gentle as possible, and we will solve your problem. So I will start by looking around the patients if there is any oxygen cylinder or if there is any walking aid besides the patients. And then I will start by general looking on the also if there is an ECG besides the patient, I will look on it, and then I will start by general looking on on the face for the presence of any. I will ask the patients, can you elevate your eyelid, or I help them help her with that, and then for looking for any erythema, looking for any erythema or malar lash in the face or any xanthelasma, I will ask the patient to open her mouth and protrude her tongue to look for any central cyanosis and look for the oral hygiene. And then I will start by assessing her hand, and then by seeing the capillary fill time, and then I will look for any clubbing or any signs of infective endocarditis, like rust spots or osler nodes or Genway lesion, and or splinter hemorrhage, and then I will assess the radial pulse and define and see if there is any radial delay, and count the pulse. Then I will ask the patient if she has any pain in her shoulder, and they will ask her to elevate her arm, and then assessing if there is any water hammer pulse by putting my hand on the half of her arm. Then I will measure the blood pressure, and then I will start by and then I will go for the chest. I will look for I will first I will kneel in my knees and look for the visible, if any, for the visible pulsations of apical for the apical pulsations of the apex of the heart. Then I will look for the chest and ask the patients to take out the gown, to look for any scars in the anterolateral or posterolateral chest, or anterolateral or posterolateral. Then
yes. Yes.
should I continue?
Yes, please. Sorry, I got disconnected.
Yes, the fourth intercostal space parasternal line for the tricuspid, and the second intercostal space, left second intercostal space for the left for the pulmonary and right for the aortic. The patient, there will be as I go above, there will be the sound will be low, so the patient has mitral. I will hear the mitral sound. There is and ask the patients to go in the left to do in the left lateral positions and take a deep breath, and then here by the cone of the diaphragm there will be accentuations of the sound. So it is a pansystolic murmur, and also there will be a propagation to the axilla. Then I will hear if there is any carotid thrill, carotid murmur, sorry, and also here the back of the back for any basal lung crepitations, and also I will press on the back for any sacral edema, and then I will look for the leg of the patient if there is any lower limb edema, or if there is any scar, harvest scar, especially in the great saphenous vein course.
Very good.
I will thank the patients and help him to dress.
Yes.
And wash my hand, and then start my introduction.
Presenting your case. Yes.
Yes.
Exactly on time. Can you please present your case now?
Okay, today I do examination of Mrs. Smith, 50 years old, presented to the emergency by the sudden chest pain. On inspection, there is no oxygen cylinder or any walking aid around the patients.
Very good.
And there is no drug besides the patients like warfarin. The patients on inspections, on general inspection of the patients, there is no any signs of the neck veins is not congested, and the carotid pulse is equally felt on both sides, and there is no xanthelasma, or there is no malar lash. On an inspection, the pulse of the patients is has a normal radial pulse around 90. There is no radial delay. There is no clubbing or signs of infective endocarditis, and there is no water Hamel pulse, and the patient blood pressure is around 120/70. On an inspection of the scar, there is no previous scar of valve replacement. However, in the anterolateral posterolateral side, and
yes. So what are your provisional diagnosis or differential diagnosis?
So my differential diagnosis is pansystolic murmur, as is mitral regales.
Okay. What else would you do to complete your examination?
I would do also ECG and echocardiography and cardiac enzyme and INR.
Okay. How do you suggest to manage this patient?
Manage?
Yes, management.
Yes, I will manage the patients by according to the CRISP protocol. I will manage the patients according to the protocol by maintaining patent airway, proper breathing, and adequate circulation. And also, I will start looking for the charts of around chart of the patients, and demand the appropriate the bloods, and arrange for doing echocardiography. And
can you name the condition in which you'll hear the pansystolic murmur?
Mitral regales.
Okay, good. Then what should be the management that you'll offer to the patient? Think like this.
I will liaise with a cardiologist.
And your MDT team will discuss it, and then?
And then I will give start giving assess if the patient is diabetic and hypertensive. I will counsel for stopping smoking and also discuss the medication she is taking for hypertensions and liaise with a cardiologist and the multidisciplinary team to prescribe a suitable drug for her until we get the echo.
Yes, and then ultimately you'll advise surgery, mitral valve replacement.
Yes.
Okay, good. Okay, can you please tell me why you thought that this is mitral valve regurgitation and not aortic stenosis? What are the differences? In examination, how would you have known if there is aortic stenosis?
If what the difference between mitral regurg and stenosis?
Yes, please. In examination, how would you know if the patient has aortic stenosis, not mitral valve regurgitation?
Aortic stenosis?
Yes, please. Asking
Aortic
you what,
stenosis.
how
Yes,
would you
aortic
know?
stenosis. There will be ejection systolic murmur in the second right intercostal space, accentuated by leaning forward and propagated to the carotid area.
Yes.
Also,
So,
the patients will be most probably will be a male and higher age than that, plus 6.
this is also elderly lady. So when they are old,
Yeah.
it's all right. So, okay, if you'll do the ECG, how do you
And
expect the ECG to be? Can you please help me to read this ECG?
there is a positive lead 1 and the AVL, and the negative lead 2 AVF. So is positive lead. I then assess a pulse. Heart
Yes,
rate, I will count the heart rate.
yes. What will
Okay.
be the heart rate? So you have to tell what these pluses are and what these minuses are in the blue circle and the red circle. And what you, on the basis of your examination, when looking at this ECG, then you have to tell me again, what are you convinced with? What are your differential diagnoses?
Depending on this ECG.
And your examination, yes?
Here is there is absent B waves.
Okay, this is aortic stenosis.
This is mitral.
Aortic stenosis.
I suspect stenosis. The patient is smoking and hypertensive, but
No,
I
but
know that
your diagnosis was aortic regurgitation. Here it's radiating to her left arm and shoulder. So I kind of tried to give you history that it's radiating there and it's already on the carotid region. So it's not on the heart or on the mitral region, because if you would have listened to, if there was a real patient, real patient had mitral regurgitation, then there'll be audible pansystolic murmur, audible, right? But here in this situation, I'm already giving you little bit history that this is what's happening. So more, and it's sudden, and patient is diabetic, hypertensive, and smoker. So most likely differential diagnosis. But even if you'll say mitral regurgitation, then you have to justify your answer on the basis of ECG. They might give you ECG and they'll quickly ask you to calculate RR interval, the heart rate. So you'll quickly calculate the RR interval and you'll tell the findings in ECG. And then on the basis of this ECG, and then on the basis of this history that you have taken, this examination that you have done, you have to justify your clinical examination, have to justify your differential diagnosis. Because even if you're saying it wrong, but then you have your reasons why you said that, you'll pass. But if you cannot give the reason, they will not pass you. So here, history tells you something, but still, if you say it's aortic regurgitation, then on the basis of ECG, you have to justify why you think it's aortic. This is mitral regurgitation, not aortic stenosis, right? So that's all the little feedback or points on me. So as long as your examination, I think you covered everything. In the middle, I got disconnected, so I couldn't hear everything, but I'm sure you covered everything. So anyone else wants to give feedback?
Can I? Hi, everyone. Can I add something?
Yes, please.
It's very nice, informative presentation and examination. I want to just add some points. You examine a lady, so we need a chaperone.
No.
Yeah.
No.
For for female examination, chest and genital and sensitive area, you should put a chaperone.
Okay,
chaperone,
not for every case. For cardiovascular examination, I've had one.
You should because this is the female, and you should examine the epic speed, move your breath. We need.
No, but
that.
she's taking off her shirt, but keeping her bra. She's not taking her whole clothes off. So here
Okay.
you don't need a chaperone. This is what I tell you. Only the purpose if a female patient comes and you have to do the breast examination, then you'll ask for chaperone. If it's a female patient and you have to do groin examination, then you'll ask for chaperone. If it's, yeah.
As you like, but I asked about this. The surgeon here, he said we prefer to say we need help to be in safe side. This is one. The another one he said a drug like warfarin. So the name of drug, it's mean addiction, heroin, cocaine. So warfarin is medication. So we should differentiate it between the drug and medication. We said, if you said, are you taking a drug? That means, are you addicted?
Yes, I understand you are going for the literal meanings, but then once he's presenting, he can just because he would be presenting it to the examiner. Then if he uses the term that I looked through the drug chart and there were no drugs or medications mentioned like warfarin, like he told me. So I think in that context, it's not a big deal. It can go through. It can be ignored.
Yeah.
But in the literal meaning, yes, drugs are drugs, which can be used as a substance of addiction. And then you have to use the term medication. This is very nice practice. They can do it already.
Ma'am, can you discuss the ECG?
Yes.
Or anyone can tell how to read the ECG? The last
Dr.
one.
Taffer, can you please read the ECG?
So for ECG, we said we're looking for we're looking for rate, rhythm, regularity. So
Yes.
we measure the square between R to R because it is regular. So then measure how many square between 2R and divided by one, it is 3 divided 30, so it is about 100 rate. So we said regular 100 rate, positive R in lead 1 and AVL, that means left axis deviation. And deep S in the 2 and 3 AVF, that means also left axis deviation. It goes with the aortic stenosis.
Good. How would that have been if it was mitral regurgitation?
because it is left axis deviation, so we have heart enlargement, ventricular heart enlargement, so axis deviation to the left side.
Yes, Dr. Abhishek, would you want to add anything?
No, I was just saying about this ECG. Dr. Duffer
Yes.
actually said like there is some positive depolarization in the left 1 and AVL and negative
Yes.
1
Yes.
in lead 2 and AVF. So whenever between lead 1 and 2, they're going away from each other. So it's a quick mnemonic actually, quick tactics to know
Yes.
that
Tell
whenever
them
they're
because
going
their
away,
time is
something like that.
less and they need
Yeah.
something like this to.
So in you'll look for Dr. Mohammed, you'll look for just lead 1, 2, and 3. So if 1 and 3 actually going away from each other, so it means there is some kind of left ventricular hypertrophy. So you can see that there is aortic stenosis, right? In the ascending aorta, there is some kind of aortic valve stenosis. So the left ventricle has to pump blood against this stenosis, so it will be hypertrophied. So whenever it will be hypertrophied, there will be left axis deviation, and it will be presented as like this ECG, that lead 1, 2, and 3, there will be between 1 and 2 and 3, they will be going away from each other. So whenever there will be pulmonary stenosis, some kind of that, like then there will be right ventricular hypertrophy and right axis deviation. And in that case, you will find that all the depolarization in lead 1, 2, 3, they will go in the same direction. Okay, so there will
Very
be all
good.
positive,
Yes.
positive
Now
positive
they'll remember this.
depolarization lead 1, 2, 3 to be
Good.
like to answer quick in the examination. You can also read the heart rate definitely. So before reading the heart rate from an ECG, just you have to look first that if the rhythm is regular or irregular. So in that lead, you can see that there is more or less same distance between two RR interval. Then you can follow that tactics. Okay, 300 divided by number of large square between two RR interval. But there is also another station like atrial fibrillation. So there will be some irregular rhythm, right? So in that case, you have to measure that number of QRS in 30 blocks. So in 30 blocks, actually, each block actually indicates 0.2 seconds. So in 30 blocks, there will be 6 seconds, right? And multiply it into 10. So then you will get the heart rate from the ECGs. So these two things
Good.
are actually asked in the examination.
In the exam, yes.
Yes.
Good. Thank you.
Welcome.
And should also I know ECG of other lesions like mitral stenosis and
No, atrial fibrillation they'll give you.
Atrial fibrillation, and another is I have told you. Sorry, this one atrial aortic stenosis and atrial fibrillation. These two
Yeah.
actually are given in the
Are
examination.
given. Yes.
Yeah.
And you can easily tell the difference. RR interval will not be the same. So you'll
Yes.
easily tell. Okay. Good. Thanks.
Welcome, ma'am.
Yes, I'm ready, ma'am.
Yes, started the timer and here is your question. Right. So if you have read and understood, considering it clinical examination station, please begin your examination.
Yes, I will start by wash my hands. Then good morning, I'm Mr. Al-Ghaziri, one of surgical doctor there. Can I confirm your name and age, please, sir?
I'm Thomas, 67 years old.
Nice to meet you, Thomas. Today I'm going to examine your heart. It will include general look and feel through your chest and listen to through your chest. Do you agree with this?
Yes.
Okay. Do you have any pain at the moment?
No.
Okay. So if you don't mind, can you take your shirt clothes from waist up, please? And the examination will be done in the semi-sitting position, 45 degrees. Now I
Okay.
will take, after I wash my hand, I will take a general look from the end of the bed to see the patient is in shortness of breath and with oxygen mask or not, for ECG leads, electrodes present or not, any walking aids, and any nearby drugs in form of warfarin treatment or not. Then now I will start by a general look for the patient. I will ask the patient that can you please take your lower eyelid down and look up to detect any pallor or any jaundice. Now I will ask the patient, please can you open your mouth and stick your tongue out up, please, to detect any central cyanosis and look for any dental hygienes. Then I will ask the patient, please, if you don't mind, can you look to the other side to detect any congested neck veins? And so now I will now take a look in your hands, please. Can you put your hands in front of you? Then I will search for tar staining, splinter hemorrhage. Can you turn off your hands? I will search for Osler nodes, roses spots. Now I will squeeze your fingers to detect the capillary fur and feel the temperature from distal to proximal. Now, if you don't mind, I will feel the pulse in your hands. Then I will compare with the other side to exclude coarctation of the aorta. So now, if you don't mind, can you put your both index finger in front of each other to detect any presence of clubbing?
Good.
So please, do you have any shoulder pain? Okay, so now I will feel the pulse in your hands, but with rising suddenly your hand to detect any water Hamel pulse. So now, excuse me, I will start to measure your blood pressure. Then now I will feel other pulse in your elbow for brachial pulse, comparing with the other side. Now I will feel pulse in your neck, carotid pulse, side by side. So now, please, can you, if you can you raise your hands for me, please, to take a close look in your chest to detect any scars in form of median sternotomy or infraclavicular or any palpable battery. So now I will feed your now I will. Do you have any tummy pain? Now I will feel your tummy to detect any jugular venous hepatojugular reflux. Going to feel the apex of the heart at the left fifth intercostal space mid-clavicular line. Now I will count from below the sternal and from the sternal angle to detect the apex. Now I will listen through. Now I will feel after apex. I will feel any heaves by palm of my hand to the right and to the left of the sternum. Then any palpable thrill with the flat of my tip of the finger in the fourth auscultatory area. After that, I'm going to listen through your chest. I will start by mitral area, then the tricuspid area, left fifth, then left fourth parasternal, second left parasternal, right second parasternal, mitral, tricuspid, pulmonary, and aortic. If I detect any, I will twist the stethoscope to be the cone. We'll start auscultation one by one area. If any detection of any murmur as regard the mitral area, I will ask the patient that to lean to the left side and take a deep breath in out and search for accentuation to the left axilla. And then if I detected any murmur on the right second intercostal space parasternal aortic area, I will twist the cone for the cone and the propagation. But the most important, I will auscultate At the same time, I will feel the pulse in your neck, the carotid pulse, to detect the systolic and diastolic component of any murmur. Now I will listen to your back for any crepitation or crackles, for pulmonary edema or any signs of heart failure. Now I will press in your back for sacral edema. So I am going to examine your legs. I will press little bit on your chins to detect any lower limb swelling or lower limb edema or any
Your
scar.
time has gone. Can you present your case now, please?
Yes, today I examined Thompson, 67 years old male who attended for elective right side inguinal hernia repair. On examination, there is no malar flush, no oxygen aids. The apex is with bulbable carotid pulse, no heaves or no thrills. Apex is the left fifth intercostal space, mid-clavicular line. With no audible metallic click and pacemaker scar infraclavicular
Good.
with bulbable like battery.
Yes.
On examination, on no heaves, no thrill. On auscultation, there is a metallic click of suggestive pacemaker, and at the base, mild crackles or crepitation with lower limb edema also, but normal S1 and S2 heart sound with no visible scars for any surgery in the lower limb.
Yes.
So
Considering that it's a pre-operative patient and would have to be operated, would you allow the patient to go ahead?
what is the question, please? So to complete my examination,
Yes. Okay. The
Is that-
question is, since it's a
Yes.
pre-operative patient and
Yes.
patient needs to be operated for the right-sided inguinal hernia, would
Yes.
you recommend the patient to go ahead for the operation, for the surgery or not?
For the surgery, now I will firstly inform the anesthetist and my consultant and include the cardiologist, okay, for optimization of the patient to take a decision according to the patient. But the precaution for this patient, according to cardiologist, will optimize the case according to the mild heart failure. And for pacemaker, I will consult pacemaker clinic for pre-operative and operative precaution and advice. And take some blood investigation for INR of the patient on warfarin and the baseline echocardiography and ECG, and to complete my examination form of abdominal examination, urine dipstick fundoscopy, baseline ECG, and peripheral vascular examination. But before surgery, we need to optimize the case of the patient as regard the cardiac condition.
Very
And there is a little precaution must be considered as regarded this patient in form of the liability for thromboembolic manifestation.
Very good.
Yes, as regard this patient is with pacemaker with no risk, with no lengthy operation, so is low risk. Just stop warfarin if the patient on warfarin 5 days before the operation, and start once oral fluid can be accommodated, but after the consultation of hematologist and the local policy of the hospital.
Very good. Okay.
Yes.
Quickly, you have to practice saying all this quickly. You were saying it correct, so I allowed you to talk. Okay. If you look at the ECG, what this circle is telling and what are these arrows? Please quickly. Can you read the ECG?
Yes. This is what's called electrical stimulus pacemaker with characteristic spike, suggestive of
Okay.
the patient with pacemaker. Yes.
Very good. And
Yes.
these arrows are showing what?
Spike of the
Okay.
pacemaker. Yes.
All right. Can you mention or can you name few indications when pacemaker is needed?
Yes, first one, symptomatic sinus bradycardia,
Very
symptomatic AV node disease,
Very
SA node
good.
disease, long QT interval, hypertrophic obstructive cardiomyopathy, dilated cardiomyopathy.
Okay. Can
Yes.
you please tell me what are the clinical differences? Bell is gone. Now we are just discussing because in examination you should be prepared. So Bell has gone. Thank you. I'll give you feedback in a second. I just want you to tell me, can you tell me the differences between the right-sided heart failure and the left-sided heart failure?
Yes. As regard the right side heart failure, the patient was presented with what we called as ascites pericox, right enlarged tender liver, congested neck veins. Okay, and there as regarding the the left side heart failure, the patient will be presented as paroxysmal nocturnal dyspnea or sopnia and lower limb edema.
Very good. Okay,
Yes.
good. Thanks. Other questions? You already answered them before I could ask you. So this is good. So this is another ECG that can be asked. So you can see how this ECG is different. And you can see it's not normal.
Absent B wave.
Yes.
Yes, absent B wave with characteristic spike.
Yeah. Good. Thank you. Right. Started your timer and here is your question. Right. If you have read your
Yes, I'm
scenario
ready,
and
ma'am.
considering it, yes.
Yes, I'm ready, ma'am.
Okay. Considering it critical care scenario, kindly tell me how would you manage this patient?
Yes, this patient will be, I will manage this patient according to ETLS protocol through ABCD approach. I will start by cervical spine immobilization in form of hard collar, sandbag, and tape. But
Yes.
airway patency, I will search for it. If the patient can talk, there is patent. If it can't be talk, I will search for look, feel, and listen. Look for any foreign body or any maxillofacial injuries, and listen for an abnormal sound in form of snoring, wheeze, or stridor. And feel this is as regard to listen, and feel the press on my cheek. So as regard, if there is no patent airway, I will start by jaw thrust, chin lift. If with high oxygen with oxygen mask. If no response, I will go for nasopharyngeal, oropharyngeal airway. If there is difficulty in this, I will go for more advanced procedure in form of I will ask for help from expert anesthetist for endotracheal intubation. If any fracture of airway edema or fracture of the larynx, I will go through surgical airway in form of cricothyroidotomy or open cricothyroidotomy or tracheostomy if fracture larynx or airway edema. This as regard the airway. As regard the bracing, I will go for look for any chest wall movement expansion, symmetrical or not, open or closed flail chest, open chest injury. I will feel also.
Okay, Dr. Mohammed, patient had a right crushed leg. So how
Yes.
would you evaluate how much blood loss patient has had?
I will assess according to C circulation, blood loss according to the pulse, blood pressure, urine output, and mental state, and the blood pressure and the mental status and the peripheral warmth. This and
Patient
will
is unconscious.
yes.
So how would you assess?
Grade of the shock
Yes.
according to the pulse. Firstly, by grade 1 is less than 100, grade 2 from 100 to 20, grade 3 from 120 to 140. More than 140 is grade 4.
So you think patient is grade 4 hemorrhagic shock? How should this hemorrhagic shock be managed?
The management of hypovolemic shock will start by 2 wide bore cannula, IV access.
Yes.
Will give the patient at least 2 liters of crystalloid initially over 1
Yes.
hour.
Yes.
Then at the same time, I will cross match for 4 units of blood transfusion
Yes.
for blood units. Then I will search for any visible source of bleeding in form of the 5 area: floor, long bone, chest, abdomen, and pelvis. And at the same time, I will order fast to detect any internal bleeding. And search and will put the patient on the monitor, a blood sample for full blood count, glucose, urea, and electrolytes, and
Okay.
VBG. Yes.
You've received the lab results, and it shows high urea creatinine and electrolytes potassium is raised, and you
Yes.
see the urine in the dipstick. What does that
Yes.
mean? What's happening to
This-
the patient?
Yes, this is mean what we call crush injury or crush syndrome
Yes.
with acute tubular necrosis due to obstruction by myoglobin.
Yes.
With lysis of with increased potassium in the blood.
Yes.
And detect of myoglobin in the urine.
Okay, but what
Yes.
is happening? It is causing acute kidney injury, right? So
Acute kidney
how?
injury. Yes.
Yes, I want to know how would you manage this
Yes, I will,
rhabdomyolysis with
according
acute
to
kidney injury?
Yes, I will first I will as I mentioned, start with IV fluid to increase urine output to be more than 300 per hour or until myoglobin is seized or from the urine. I will give the patient forced diuresis in form of furosemide and alkalinization of the urine if possible.
Okay,
Um,
yes.
Yes, and correct, the most important correct of electrolyte disturbance, the most important is potassium by cardiac
Yes.
monitoring, and give the patient insulin with glucose for potassium influx, and cardioprotective, they give the patient calcium to antagonize, or give the patient also a salbutamol as a beta-2 agonist to for influx of the potassium intracellular also.
Okay,
This
so what blood test would you do while you're monitoring or taking care of raised potassium level?
yes, renal function, lactate, and LDH, and the serum calcium.
Lactate, okay, LDH and yeah,
Yes,
elevated CKMB.
yes, yes.
All right, and all right, okay. What
Yes.
else do you expect to find in the urine? What is myoglobin?
Myoglobin is, I mentioned that positive myoglobin in the urine.
Yes, what is myoglobin? Sorry, I asked.
Myoglobin is oxygen protein binding that is present in the muscle.
It's a pigment found in the cardiac and skeletal muscles. Okay, can you please tell which carries oxygen? All right, can you please tell me what are the clinical features that you should look for if you are suspecting patient to be suffering from compartment syndrome?
Yes, as regard compartment syndrome, as regard symptoms, the pain will be out of proportion of the injury, and with acute pain on passive stretching of the swelling of the swollen leg, with the loss of pulse, and 2-point tactile discrimination, paresthesia, or
Yes.
of the limb, which indicate impending limb necrosis.
Okay, what should be the normal compartment pressure?
If compartment pressure
Yes.
up to 25, more than 30 need fasciotomy.
Yes, up to more than 20 needs fasciotomy, but normal is between 0 to 15 millimeter of
Yes,
mercury.
yes,
Okay.
yes.
What is fasciotomy? How is it done?
Yes, fasciotomy is done by 2 incision, dividing the antero and lateral, to dividing the anterior and posterior facial septa between the lateral compartment, anterior compartment, and the posterior compartment.
Okay,
two
it's an
incision.
emergency surgery, emergency procedure. Okay, can you please
Emergency
tell me
procedure. Yes.
what is rhabdomyolysis? What can be the causes of rhabdomyolysis?
Yes, as regard rhabdomyolysis, maybe lead to maybe occurred from crushed injury,
Yes.
and
Yes.
can be with tight cast, severe burn,
Severe burn,
and
yes.
also maybe reperfusion injury may occurred also.
Yes, reperfusion injury in the acute ischemia.
Yes.
Okay, last question, Balazwan. Can you please tell me how would you monitor this patient? Exactly what are the things that you will
Monitor the patient.
Yes,
This
please.
patient will be monitored according to clinically the level of consciousness, and
Yes.
according to the most important according to the acute kidney injury, the urine output amount, the absence or cessation of myoglobin from the urine, and according to laboratory investigation, electrolytes, cardiac electrolytes, urea renal function test, and also cardiac monitoring for electrolyte disturbance,
Very good. And capillary refill time as well.
and the
Very
capillary
good.
refill according to the hemorrhagic shock, the
Very good.
parameters I mentioned. Yes.
Yes. Okay, good. Right, thank you.
Thank you.
Who is the doctor?
Asking, and here is your question.
Yes, I'm ready, ma'am.
Just 10 seconds, 9
Yeah.
seconds.
Need to change this.
Why I cannot mute Dr. Ninjrol. Okay, so if you have read and understood, considering the communication skills station, please begin.
Hi, good morning, sir.
Good morning.
Just for safety, can I confirm your name and age, please, sir?
I'm Jafar, 35, 6 years old.
Yes, nice to meet you.
Me
Mr.
too.
I'm Mr. Ghaziri, one of surgical doctors here, Senior Registrar T1. I have
Okay.
been asked to talk to you about an investigation we would like to arrange for you. So firstly, if you don't mind, can you tell me us what you know so far about this, please?
Yeah, I received message from, they told me there's something called endoscope. They passed to show my upper pipe, GIT pipe, and looking for stomach. Is that okay?
Yes. So thank you for your information, but if you don't mind, let me explain for you in more details, if you don't
Yeah.
mind. So let me explain for you that that's what we call OGD, and esophagogastroduodenoscopy, that can be abbreviated in form of OGD. Simply, it is a camera test which is called endoscopy that can be introduced, as I will show you now in this paper, can be introduced through your mouth, then downward through your food pipe. After that, will pass through your stomach, which is your food reservoir, then through the duodenum, which is the first part of the small bowel. This camera test will relay an image on a TV monitor or screen, also to take a photo, to take a look inside. But also we can make a widening to the lower part, the narrow part of to the narrow part of your foot pipe that have been results or mentioned in your contrast scan that we called barium image. Also, we can take a few samples from the lining of your foot pipes, and this will be done through introduction your teeth under sedation that will make you that like drowsy and feel no pain. So how does that sound, sir?
It sounds good, but
Yeah.
I feel it's difficult. But if there is any option,
So yes, I do appreciate that your apprehension at any patient regarding investigation that can be done to figure out any case. But as regard your case, there is no another available option after we have mentioned that you did barium image or scan image. So
yeah.
we need in this case to have a look inside. So the available and the only option we can do, we must have a look inside. Is that clear, sir, or you have another idea?
Yeah.
It's clear. So during this operation, I'm waked, or you give me some medication for make me more comfortable.
Yeah. So that's a good question. As regard, I mentioned that this is a procedure or investigation will be done is a day case surgery. Will be done under sedation. That you will feel drowsy a little bit. You will not have that sensation of the procedure. Just you will feel no pain. As it take about a short time, so no need to be done under general anesthesia or formal anesthesia. Is that clear or any issue?
Yes, it's so clear. Thank you for this presentation. So I decided to go with the OGD. I think it's better for me.
Yeah. So,
Ask about any risks.
but but I wanted to emphasize a certain important thing that this procedure potentially has a risk as any procedure. So I want to emphasize this before counseling you formally and before finishing this counseling session. I will mention some of this risk to inform you about this. The first one in form of injury to your teeth through introduction of the endoscopy. The second one may be infection in form of chest infection. The third one may be bleeding from the site of tissue sampling, as I mentioned. But the most significant, the most risky is may cutting through your food pipe that may need a surgical procedure or operation to fix it and for repair. So how does that sound according mentioning this risk factor?
Yes, it's good. So I just want to ask about can I eat around the operation before, after, when?
Yeah. Yes, this question as regards the preparation before, you need to fast from the food at least 6 hours, but according to the clear fluid or water 2 hours before. If you receive any regular medication, you can take it just a little bit before the operation, but with small sips of water. I get your point of view, or not yet?
Yes, it is clear for me. I just want to ask about the results. It take how long time to be available, and I know the result.
About the time available for what? For the
Result.
operation?
For results. For results of this procedure.
Yes, usually, yes. I do appreciate your apprehension and the concern about the result, but usually we did these investigations within the result within 2 weeks time frame. But as regard your apprehension, I promise you that we will contact you as soon as possible once the result appear. How does that sound here?
It's good. Thank you very much for informative information for today. Thank you very much.
Yes, but at the end, in
Yes.
summary, and I will recap some important points. You have to attend to the operation or procedure at the time at the morning, but one must accompany you, as you will not be eligible or available to drive to your
Good.
home, and he must accompany you and be with you at least 24 hours with you. Okay, and you will be discharged from our hospital when we make sure that you regain your full conscious level and you are aware. Additionally, the vital sign in form of your blood pressure and pulse are well and good. After that, we make sure that you did well recovery. We will be able to discharge you. Is that clear, or you don't have any question to be recapped or summarized for you?
No, thank you very much for your informative. It is complete your all my answer question. Thank you very much for your time.
Yes.
Regard.
At
Thank
the
you.
end, you say, if you understand, then you can sign the post. He has
Yes.
to sign the consent paper.
Yes. Now you have to sign the
Okay.
legal document
will.
for
Good.
on the
Good.
consent for it. Yeah. Thank you for it.
And
Yeah,
at the
thank you.
end, Dr. Mohammed, you can add that if still you have any other questions at any time, so you will leave your number with the nursing staff. You can contact. You can get.
Yes. If you have any other question,
So good.
you can ask the sister to call me or SHO in charge in behalf of me. Yeah.
Okay,
Good.
that's fine.
Thank you.
Yeah. Thank you.
So now feedback. It was very good, very impressive. Yes, but I will let Dr. Dafa to give you feedback first.
Yes, it is very nice,
Yes.
but we need to arrange more for
Yes.
communicative skill, because we looking at descriptive, and sometimes he goes in all scenario and don't let me to ask or for sedative for it is not communication, actually communication. We need more train up in this situation. For example, in Egypt, when I visit Egypt, so the people is highly familiar with me, communicated. So we need to act like that in future.
Yes, but
Yeah.
considering it was the first station, I think it was very good.
Yeah,
But
it's very
then
good.
again, it's virtual. You are not looking at anyone. Cameras are not on. And
Yeah.
considering all this, depending only on the voice for each other,
Yeah.
I think it was very good. And
It's
both
very
of you had a good communication with each other, because he understood your questions and he answered you promptly
Yeah.
accordingly. And you conveyed or you asked the questions also accordingly, because you knew the station. So yeah, that was also one factor. But in the exam, there will be the patient, maybe the actor, most likely the actor, and he or she may not be as cooperative as you are. So in that scenario, if patient continuously resists and says no, I'm still not convinced, then it will be a difficult challenge for Dr. Mohammed. Keep on convincing the patient. But like if he will keep on saying what small things that he has said today, I think he will be able to convince the patient in exam as well. Because here two examiner will be sitting and they'll be looking at how you convince the patient.
Yes.
So I have, excuse me, ma'am, I have
Yes,
just one question.
yes, please.
That's as regard patient or actors will be resistant either in the counseling for take a consent or for angry patients.
Yes,
If the actor persists for resistant till the end or to near the end of the session, can I offer that Yes, I appreciate, or I do appreciate your opinion. So let's take the opinion of our consultant to make another counseling session
No,
with you. No, no, it's not available.
no, it's not the right way of saying it. Actually, they want to test you, not your knowledge, your
Yes.
compassionate. How, in these scenarios, how would you react? They want to see if you'll get angry or you'll give them offer other alternatives. Like if you offer them another appointment with consultant, that means
Yes.
you're running away. You are not taking responsibility yourself. You're handing over your responsibility to someone else. And this
Yeah.
is not the scenario in which you will give it over. In this scenario, in this exam, they only want to see how you will handle. If patient is very naughty, very resistant, very angry, you don't have to get angry, right? And then you have to
Yes.
use the tactics. Can we just sit down and talk? Because this will be like face to face. You will have patient in front of you and you're not going to get angry. Patient is continuously saying no, 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 and you're continuously calm as you are trying to convince your patient. And you can say, okay, can you please just sit down and we can talk? Would you want to have a glass of water to relax you down? And then you can offer something like, okay, if you're having pain, I can maybe arrange analgesics for you. Would you like to have an analgesic? You can offer water. You can ask them to sit. You can offer them a chair. You can ask them, if light is disturbing you, should I turn it off or should I dim it? So you can offer all the other possible alternatives, but
Yeah.
not another visit, because whatever
Yes.
you have to do it in this visit, and you're not giving up. So examiner will be looking and listening that you are offering alternatives which are in your hands. You're offering patient to sit down, you're offering chair to sit down, you're offering painkiller, you're offering glass of water to drink to calm down, you're offering light to be turned off because it's maybe irritating you, or anything. So these are the options which are in your hand and which are
Yes.
available, and you are offering these. And then if still a patient is angry and still behaving in the same way, okay, then you say, all right, I'll give you time. You can say whatever problem you have, and then I'll see what I can do about it. So you'll
Yeah.
give them the full chance, vomit it out, whatever is in their heart. But after, like, you have tried all these, I'm sure patient will smile itself and will say give up. And then this will give you the highest marks. But if you'll
Yeah.
offer them another appointment with consultant, so this will not, I'm sorry, this will make you fail, because they will think that you're trying to get rid of your responsibility. You will not take the headache, you'll not take the challenge. So you have to do it yourself.
Yes. Adding to this point, please, as I will explain or demonstrate a real situation occurred to my friend
Yes.
in UK, that as regards the station of the wife, angry wife,
Yes. Yes.
whose husband has cancer cell in tummy swelling.
Yes.
The issue for this wife, that the registrar, not the candidate, the registrar who offered the SHO to communicate with the wife,
Yes.
told her husband that he has cancer.
Yes.
So she mentioned that my husband is astonished now. What will what we can do? What we can do now? And she insisted that, please tell me what we can do now, away from the CT, away from the figuring out the issue. However, just the her husband is astonished. So in this case, we can offer that we can counsel your husband now in joining with me and you. And if we need any upset or so, we can include socially or psychiatrist to manage this emotional state away from the management of the proper diagnosis of cancer. Is that right or not? I just ask, not answer.
No, if you'll not answer, it's an angry vibes station. You cannot choose not to answer. So you have to adopt accordingly. You have to adopt accordingly, and you have to answer the way you answering. It's all right. You can say, okay, if your husband got, I'm really sorry to hear that. You first you
Yeah.
have to be very apologetic. I'm really sorry to hear that your husband has been astonished and it has taken him like a shock. But since you already knew, so you bring it back to the patient or to the history of the patient or to the wife. Bring it back that already you knew that patient condition was not good. His tummy was swelling and he was not him and his condition. So you will bring it back somehow. You'll bring it back to the history that they had. So it should have been in their mind why it has been astonished or it has been an astonishing news for them. So in this way, you'll offer that, okay, we can, if you want, then I can talk to your husband and we can offer all the possibilities. We can even arrange with the psychiatrist or with the church or whatever they want, or with the social help or the counselor or however they want. I can explain it to them. But then here you would have to bring it back to the history of the patient, what
Yes.
sufferings he was already going through. So it should not have been a shocking news. Patient should not
Yeah.
have been astonished.
Yes.
So here
Yes.
you have to, cool down the woman, but you have to
Yes.
answer. You can't
So
get away by not
yeah.
answering.
So we should in steps. Just I to avoid taking more time. Really sorry. Do apologize.
Yes,
We every patient must have the knowledge of his case,
yes,
but we need to arrange emotionally, and we make a network of support from our team or family or friends to make sure that we are behind him till figure out his condition, and to avoid making him upset about his condition. Is that right or
yeah,
enough
yeah.
or not?
Yeah,
Yeah.
it should be
Okay.
enough. But if
Yes.
then it depends on a patient. You have heard this story, but then
Yes.
if you were in the real scenario like this,
Yeah.
these actors, they realize,
Yes.
they notice that in which area you are weak and in which area they can stress to pressurize you. So
Yes.
you have to handle these sort of things. You have to manage, like it's like a theater. You have to act politely and humbly and apologetically. So you are doing it like you're playing a very safe game, a very safe game. Here, knowledge is not that much important. Here, it's important how you communicate with them, how you handle them, how you manage them. So in that, we can do this scenario tomorrow. You can prepare this and
Yeah.
revise CT scan
Yeah.
one, or yeah, we can do that tomorrow, and we'll see how it happens. Dr. Duffer
Yeah.
will read more and we'll make it sound like the
Yeah.
Yes.
real
Yes.
examination.
Thanks, ma'am. Thank you very much.
Right, thank you. But it was good. Your today's performance was good.
Thank you.
And here is your question. I think it's not the same one.
Yes. This is good.
Is it the same?
Yeah. Yeah.
Okay. Right. So if you have read and understood, considering it communication skills station, kindly begin.
Yeah. Hello, I am Dr. Dafur, one of the surgical doctor. I have been informed to contact you. They told me you want to leave the hospital. Could you tell me why you decided that?
Yes, doctor. I'm sorry, I'm not comfortable here, and I have the personal issues, so I have to leave now, please.
Okay, I appreciate your concern, and I'm very sorry. I'm very sorry to hear that. I want to say we admit only people that need a good active observation. I understand. I can imagine how the admission, how the life in the hospital, it is disappointed and frustrated, but you need a good observation. For that, we need to admit you. Is that okay?
Yes,
And
that's okay.
yeah,
But
and
whatever my case,
yeah,
I have to leave now. Excuse
okay.
me.
Yes, I appreciate you. I respect your decision, but I need to explain your conditions. Firstly, you're suffering from the fracture rib in the left side, and this causes injury to the organ that's called spleen in the left hypochondria. So will lead to what causes bleeding subcapsular. It is maybe serious, yet, and your hemoglobin drop 1 gram. So it may be rebleed or continuous bleed, and that make your life in danger. This sounds good.
No good, doctor. I have to leave as my wife has an issue as regard her health, and I need to attend the session with her doctor, as her health is critical. So I must attend.
I'm
Please.
really sorry for your
Life situation. Yes.
I'm really sorry for hearing your wife complain. I respect you're lovely. You want to attend to help your wife, but you should looking for yourself first to be to looking for her in the future. If you get any worse, you cannot follow. You cannot help your wife in the future.
Sorry, doctor, I have to go. Excuse me. Don't
Okay.
don't make me embarrassed, please. This is my wife.
Yes, I appreciate. I said I appreciate that. I just want to repeat what I say about your condition to make sure I give you a good idea about your condition.
Yes, doctor, you mentioned that I have fractured ribs. I don't know what about fracture, but it may lead to a danger to an organ present in my tummy, which is suggestive of ongoing bleeding. I get this information from your counseling.
Yeah, that's good. It is correctly.
But
I want to.
I have
Yeah,
to
yeah,
leave. Yeah, I have to leave.
yeah. We
Talk
respect.
about your interview for
Yeah.
Fair Eyes.
Yeah. So for you decide that we respect your option. So according to that, we need to assign some paper because you discharge against the medical advice. So we need to sign these paper. Can you sign these, please?
Yes, but before I sign,
Yeah.
if I go away, how can I look after my health, or must be aware for any alarming symptoms or signs for my life to avoid
Okay.
my safety? But I don't want to go away and lost my life. I search
Okay.
for the life of my wife, but I must search for my life also.
Okay. That's good. So if you develop any sign, a deteriorating sign such as increased abdominal pain, or become drowsy, lethargy. So you should return back to emergency department asking about me. I will give you my contact, or contact any SOH or responsible in that time.
Yes. Yes, doctor. So now I am ready to sign the local document, taking all the full responsibility for
Okay.
this issue as regard my life.
I need to summarize. Before you will go. So you decide to discharge against the medical advice. You sign the paper. We told you about the risk, and you accept this risk. And we told you about the warning sign if they develop, and we give you the contact, how to contact us. So everything. Do you need anything else? Do you asking about anything else?
Yes, the last question. If I
Yes.
experience pain, can I take any painkiller or analgesia from any shelf, or
We cannot, because you.
I need a special painkiller. Any obstacle for receiving any medication, any food, and what about the precautions for me for continuing my lifestyle, my exercise, my work? Is there any constriction, any obstacle against this mentioned activities?
So we cannot prescribe the drugs for you, because medication for you, because you assign you self-discharge. You decide to self-discharge against the health advice, but we can use some over-counter analgesics such paracetamol or any other. For activity, we should keep lie in the bed, and it is better to stay in the hospital, because we are all looking after you.
Yeah. Thank you, doctor, for your explanation, your attention, and if any risks or any warning symptoms or signs you have mentioned, I will attend to A&A department. Will contact you directly or SHO in charge. Thank you for you. Thank you.
Thank you very
Regard.
much.
Thank you.
Yes, exact on time. Thank you, both of you. Right, Dr. Lafar. First time you're presenting, and then considering it's a communication skills station. So there are 2-3 points that you could have added when patient told you about the wife problem. Then you should have offered first that, okay, I'll talk to your wife, and patient will decline it. Then you can offer, you did say that you should consider your own self first, but then you could have also offered that we will arrange social worker, and we'll find a way to offer help to your wife. You
Yes.
do not have to be there yourself. So this one thing that you could have added. And then there was another issue which patient would have said, that patient has an interview as well for pay rise. So you can also, in that instance, you can also offer that, okay, we'll talk to the employer, when then patient will again
I'm waiting for this question.
Yes.
I'm waiting for this question.
Yes, then patient will not allow you. So you then you'll tell yourself, okay, since you are going yourself and you're responsible for all the risks that can happen, so you'll tell yourself all the signs and symptoms for hematoma rupture. Yes, you did tell, but then patient made you tell.
Yes.
Right, and then you will not give any medication to the patient, because patient is going home with his own will. And if anything happens, then patient has to come back.
Yeah.
Yeah.
I have one comment, just one comment.
Yes, please.
Okay.
Yes, as regard at the beginning of the session or the counseling, you mentioned that I have fracture of ribs and
Mhm.
abdomen and spleen. So as regard fracture, maybe layman, but fracture equal crack, but it's not abdomen, it's tummy, in my tummy.
Yes,
Yeah.
in your tummy.
Yeah,
not
that's
abdomen.
that's
Yes,
correct. Yeah.
yes.
This is a layman,
Layman
Yeah.
language, yes.
yes, not not abdomen.
That's correct.
Yes, and also another one, but I have missed that. Yes, if I remember, I will tell you. But just this is my comment as regard that. And also, we can additionally offer that we can draw for the patient like a box or
Yeah.
as for a tummy that is present here. We can add also this organ has a defense mechanism function in
Yes,
your yes. This is 2 points I have a comment like this.
yes. And
Otherwise,
also
well,
blood drop,
yes, blood drop. Yes,
1
blood
gram
drop.
of blood, yes, hemoglobin you have dropped. So you
Yeah,
have to emphasize more on that as well.
yeah, yes. And in summarize, the most important that what is the condition of the patient, what is the alarming symptoms and signs for which he must attend to in department, and how he can approach the proper physician, either me
Yes,
or one can contact me, SHO in charge, or
or GP.
the doctor directly, who is the surgeon or the personal physician. Otherwise, brilliant.
Good.
Thank you.
Thank you very
Yes.
much.
Yes, with practice, we'll get there, definitely. Good.
Yes,
Thank you.
thank you.